Thank you, Dr. Opondo. Can you hear me?
Yes, we can.
All right. So I can share my screen now.
We can see it.
All right. So as Dr. Opondo said, my name is Dr. Geshaga, and I'll be presenting on safety, patient safety in the radiology department, right? So from my first slide here, this is the universal sign for radiation, which you'll find in every radiology department. The center represents an atom, and the three blades represent the three different forms of ionizing radiation, which are gamma, alpha, and beta rays. Now, radiation protection, in summary, includes all measures useful to ensure the protection of man and the environment against the hazards of ionizing radiation. In medical imaging, X-ray-based modalities, especially CT, are the main area of concern for radiation exposure and its biological effects. There are different forms of imaging modalities in any diagnostic radiology department. Those which use ionizing radiation and those which are non-ionizing radiation. So we have those which use ionizing radiation. We have X-rays, CTs, PET-CT, mammograms, dental X-rays, which are OPGs and CBCTs, and fluoroscopy.
Sorry to interrupt, Dr. Geshaga. Is it possible to put that on presentation mode?
Okay. Just give me a minute. Better?
Perfect, thank you.
All right. And then the non-ionizing are the MRI and ultrasound. So when a patient presents in our department, I'll take you through the different stages from the point of referral from the clinician to the point where the image has been obtained and a report has been generated. So we start with the referring clinician. In our setting, in the ideal situation, a referring clinician should either be a medical officer intern, consultant, or a clinical officer. But in our setting here in Kenya, we have, we find instances where we have nurses even sending requests. We have self-requests from patients. We have even relatives who, tell a patient that, go and ask for a chest X-ray or go and ask for a CT scan, it will help in this and that. So we have referrals from all manner of people. There is no set guidelines who is supposed to refer. So when the patient now comes to the department, first of all, the department in itself, the construction of the department, the physical structure itself is built in a way to protect patients and even staff and those around the facility. So most, all radiology departments which deal with ionizing radiation have, the walls are thick concrete walls, and we have doors, windows, screens which are lead lined, or even some walls can be lead lined, which protect from leakage of ionizing radiation. So the patient comes in, presents the request form to the clinician. Presents the request form to the first person they'll find at the reception. So it could either be a non-medical staff or a medical staff who is going to pick that request form. Then from there, the request form is taken to the radiographer, the image is acquired, and the consultant then interprets. For radiology, this is a principle that is key to us, which is, we refer it We call it a LARA principle, which means as low as reasonably achievable. And that is in reference to ionizing radiation. Now, it's important to note that the harmful effects of ionizing radiation depend on the dose received or the dose absorbed. Radiation protection standards are based on the premise that any radiation dose carries some risk, and that risk increases with the dose. Guidelines for radiation dose are referred to as dose reference levels, which can be national, which are set either nationally, regionally, or even sometimes just hospital-based. There are those special groups of patients who we call vulnerable. These are the pregnant mothers and the children, whereby we have to be extra careful on how we administer the ionizing radiation. So once the patient has given out the request form, the first thing we need to analyze is that request form. The clinical summary should be well written out so that as the radiographer or the radiologist is reviewing that summary, we'll be able to tell, has the investigation, is the investigation requested relevant to that clinical summary? It's important also to get the contact of the requesting clinician in cases where the radiographer feels that maybe the imaging that has been requested is not relevant, then it's easy for them to call and have direct consultation and discussion with the referring clinician. In some facilities, or in some countries, or even in some facilities here, we have radiographers and radiologists who review the special IR investigations, meaning that if a patient has a request for a CT or fluoroscopy or a mammogram, that they are not left to the so-called mercy of the receptionist or whoever they find at the first person of contact they find in the department. These investigations are taken and given to either the radiographer or radiologist, who will go through them and decide, has whatever been requested safe for this patient, or can we use another modality which will yield, better or similar diagnostic value? Yes. Another thing that we need also to be very careful about, and has become very prevalent in our country, is to ban kickbacks, which we as radiologists are guilty of, where we have radiology centers opening up, wanting to make business. And so if a clinician sends a patient to that particular facility, the clinician gets a kickback. So that has led to a lot of unnecessary investigations, exposing patients to unnecessary radiation. So once the request form has been taken and it has been cleared, there's a lot of visible signage within departments which patients are privy to. So here we have, for example, the universal sign for radiation saying, "Be careful." All pregnant women are asked to reveal if they are pregnant, or if they suspect they are pregnant, they should alert the radiographer. The patient then moves in, it then goes under the instructions of the radiographer. So the radiographer needs to avoid repeat examinations. This can be done by proper positioning of patients, giving clear instructions to the patient to hold their breath, or breathe in, breathe out, or to not move. There's the use of lead shields, where we are able to shield the thyroid. These are the lead shield for the thyroid, This is a whole body, and this is a cap and also goggles. So these help protect the area which is not being imaged from getting any scatter radiation. With the progress of technology, we are now using a lot of digital systems. In our public sector, through what was called the MES program, Managed Equipment System Program, all 47 counties have a digital radiography system. This means that one, we lower the amount of radiation dose that the patient gets. Two, it also allows for post-processing, meaning if an image is acquired and the radiographer or the radiologist sees that this image is not optimal, previously would have to repeat the examination, exposing the patient now to another dose of radiation. But now, due to post-processing, are able to manipulate the image to one that is of diagnostic value. The radiographer should also have extensive knowledge of the machines that he's operating so that he's able to use low IR protocols. We also have what we call a PACS systems now, which are almost in all government facilities, and I would imagine private, which are PAC stands for Picture Archiving Systems, where the images are stored as a soft copy and can be retrieved in case of loss of physical copy. So if you find a patient loses their physical copy, previously we would have to repeat the examination again, exposing the patient again to more radiation, but now you're able to go into the PAC system, retrieve the imaging and even the report and give the patient. So some of the harmful effects of radiation, of ionizing radiation, can be both related to cancer related, which are things like, for example, leukemias. We also have genetic mutations, which can occur in the sort of the standard patient and can also occur in pregnant moms or exposure to babies. That's why pregnant women, we have what is called the 10-day rule, whereby imaging should be done within the first 10 days of the first menstrual period. Some other departments also have the 28-day rule, where if a patient has missed a period, then we do not expose the patient to any ionizing radiation until we've done a pregnancy test. So outside of ionizing radiation, we have other imaging modalities which are used and can also be harmful, and patients need protection from these. I'll discuss MRI briefly. MRI uses magnetic field. So in MRI, there are two things we need of concern to us relevant to this topic, what we call static magnetic field and radio frequency. So for static magnetic field, basically we are referring to the strength or the magnetic strength. For clinical purposes, a 0.2 Tesla to 3 Tesla machine is adequate for diagnosis. In some countries like Europe, they are using 7 Tesla for diagnosis, but ideally 3 Tesla and above should be used for research purposes. For our setting, using the 0.2 to 3 MRI machines, what is relevant is the interaction of the magnetic strength with ferromagnetic objects. Ferromagnetic objects, for example, would be implants, bone implants, things like aneurysmal clips, metallic objects that the patient may have, like earrings, piercings, those kind of things. So we have to ensure that when the patient presents to the MRI department, the radiographer has to ask very targeted questions. Like, have you had any surgery? Was any implant put? Get the nature of the nature of what was implanted. Is it ferromagnetic, which, for example, are iron, nickel, cobalt, magnetite, just to name a few. The MRI compatible metals are titanium, aluminum, brass, copper, bronze. Most implants nowadays we find are titanium, therefore they are MRI compatible. If you have a ferromagnetic object exposed to the magnetic field, they can dislodge, for example, implants, aneurysmal clips, which can be fatal for the patient, or even foreign bodies. We also have what we call projectile injuries, which are metallic objects outside the body of the patient. For example, wheelchairs, stretchers, oxygen tanks, which can be attracted by the strong magnetic field and cause disastrous effects. So to ensure that safe MRIs are done, proper history taking has to be taken, asking direct questions. We have proper signage warning non-radiology staff that they should not enter, and also the use of metal detectors. These are examples of the signage. We have, please do not enter, please don't pass beyond the door. This standard signage, which, if you have a pacemaker, contraindicated, or please say, if you have implants, these are some of the things that can react to the magnet, which are properly displayed in the department so a patient is able to see and identify. This is an example of a patient who's wheeled in with a wheelchair, and the picture itself doesn't need any more description. The next thing we also need to cater for in terms of MRI are what we call gradient magnetic fields, which cause neuromuscular stimulation, where post-MRI patient may feel some neuropathies, peripheral neuropathies. The GMF also is responsible for the acoustic noise. Those of you who have got into an MRI machine, the noise for some patients can be, it can be scary, or it can be irritating. So to prevent that, we use ear mufflers. We also have radio frequency fields in regards to MRI. There is patients who have thermoregulatory dysfunction, like obese patients, diabetics, or old patients, can get thermal burns. The radio frequency can also react with conductive objects like implants and jewelry, also giving you thermal burns. Also, patients who have extensive tattoos are predisposed to reaction to the radio frequency fields, giving them thermal burns. So to prevent this, we try to keep the temperatures within the MRI room at less than 22 degrees Celsius. We avoid use of blankets, and we use things like ice packs and ice compresses on patients who have extensive tattoos. In imaging, we also use intravenous contrast, which are iodine-based and gadolinium-based, or microbubbles for ultrasound. So in such patients, normally we request for urea electrolytes and creatinine values, so that if a patient's renal function is impaired, then we need to weigh the benefits vis-a-vis the risk of exposing this patient to contrast. Thank you.
Thank you very much, Dr. Gishaga. I would just like to welcome anyone with questions to kindly put them in the Q&A box so that we are able to address them as we continue with the session. I think there's currently just one question, but I have a few of my own. So as the questions are coming in, Dr. Gishaga, there's a question looking at the PACS system, and an anonymous attendee was wondering, how long does the PACS system store images for?
This, you want me to answer now or after we
Yes,
are done?
I think we can start answering as
Okay,
we wait for a few more to come in.
all right. This is varied. It depends on most facilities contract an external institution to store the images on their servers, and you can store them for hundreds of years, or even 1 year, or even 3 months. It all depends on the relationship. It all depends on the contract you have with the service provider.
Okay. Thank you very much.
Are
Is there anything else?
separated root canal files SS dangerous? Okay, I don't know what separated root canal. I know what the root canal is. No, nowadays the materials that are used for filling of teeth are compatible with MRI. For CT scan, if a patient has metallic fillings and we are doing a CT scan of the head, the metallic fillings only give artifacts. They really have no, in terms of radiation, they are not really relevant.
Okay, thank you so much. I just had a question around patient information. Whose responsibility is it to give the patient information about the scan they're about to have and what it would entail? Would that be the clinician's side, the radiographer's side, everybody's responsibility? Kindly comment on this.
Ideally, it should be everybody's responsibility. The clinician who is requesting and the radiographer doing the examination. Those are the two people who should guide the patient.
Okay. Thank you very much. I think there's also a question around contrast prior to dialysis.
Big safety of the MRI contrast.
About the safety of using contrast in patients who are on dialysis.
Okay. MRI contrast, gadolinium, its nephrotoxicity is not it's not very highly nephrotoxic, but if a patient is on dialysis, it means we are having compromised renal functions. So in some of these cases, we can give MRI contrast. Then thereafter, a patient goes in for dialysis to wash it out. So it's best to do it after the examination has been done. So I'm seeing for patients who present with convulsive disorders, what's the best investigation? You start with MRI. You start with CT scan. If CT scan doesn't yield anything, then you move to MRI, which has special protocols like seizure protocols. In terms of radiation protection, if you fear that patient might have a seizure while they are in the machine, then we can accommodate sedating the patient.
Thank you. I think there's a few more questions coming through. So again, there's one on contrast. So someone has asked about using iodine-based contracts. Are there any contraindications for this that you know of?
Yes, there are. One, if a patient has compromised renal failure. Second, if a patient is allergic to seafoods. or seafood has high iodine concentration, so then they are likely to be allergic to the iodine. Also, patients who have thyroid imbalances because of the risk of thyrotoxicosis.
Thank you very much. So I'm seeing a comment from Miriam Wangari, where she's stating that institutions should develop checklists to be checked by patients with the guidelines of the clinicians prior to having an MRI. And from what you had told us in the presentation, there are certain protocols. So you've already mentioned the seizure protocol and the low IR protocol. Are there actual checklists that can guide the clinicians and the patients? And if there are, is it possible to know where people can find them?
Checklists for true guidance prior to having an MRI itself. From my experience, checklists for patients are, most facilities don't have, like a standard form where a patient goes through and ticks, things. What happens is it's a verbal engagement between the radiographer and the patient. So the radiographer, will ask the patient some relevant questions, and if the patient needs to ask any questions, then they'll ask. So it's basically one-on-one with the radiographer. With the clinician, most clinicians, have some basic knowledge on what happens in a radiology department. So they're able to give, some basic knowledge and basic information to the patient.
Okay, thank you. And then I think also just touching on MRI, John Kangwele has also asked about patients with bone contact hearing aids. Can they go through an MRI, or is the material not suitable, not compatible, sorry?
I can't answer that question because I'm not sure the material that is used for the hearing aids. I would have to do some homework on that.
Okay, thank you very much. But I think you had mentioned some of the metals that were compatible. So I guess if we can check that whatever hearing aid the patient has only is made up of those materials, then hopefully they'll be safe.
And a lot of the time we are able to call the surgeon who did the procedure or putting the implant in. They're able to tell us the material. That's why it's important to have the contact of the clinician on the request form.
Okay. And also just touching on that, there's an anonymous attendee who was also asked about the patient history, because we're now trying to look at anything that could make the patient have a risk factor that has not come out clearly. So they're just asking if in the radiology department, whether a patient history is taken when patients come in for imaging. Also just to reduce exposure and look at any risk factors. And I think you had touched about having conversation with the person who has referred the patient, but maybe you can just touch on this again as well.
And unfortunately, if I have 10 request forms with me, only 2 will have a clear and concise clinical summary written. Majority of those request forms do not have any clinical summary, either because the clinician didn't put it, or the referral is coming from a nurse, or the referral is coming from somebody who is not supposed to be referring patients for imaging. Yeah. So a lot of the times we are forced as radiographers or radiologists to then take a clinical summary from the patient. And in terms of calling the clinician, yes, we find most clinicians are amenable to discussions on, is this relevant, not relevant? You're able to hear each other's points of views. most are, but there are a few who, respond in a hostile manner, so to speak.
Okay, fantastic. So I think as we wait for more questions to come into the Q&A, we'll take a small pause and shift gears into the lab setting. I would like to welcome Dr. Joshua Kibera, who is our second presenter this afternoon. He is an anatomical pathologist, innovator, and medical entrepreneur who holds undergraduate degrees in medicine and surgery, as well as a master's degree in anatomical pathology from Aga Khan University. Dr. Kibera is a founder of two businesses, Aroha Cancer Center and the Pathology Network, where he serves as the CEO. He has medical skills in histopathology, cytopathology, forensic pathology, digital pathology, and medical education. He will be walking us through diagnostic errors, a perspective on patient safety with a lens from the lab perspective. So karibu sana, Dr. Kibera.
Thank you. Thank you for giving me this opportunity. And for the lovely introduction. So I am, as has been stated, a pathologist. I'm CEO of the Pathology Network. These are just my disclosures. I am a medical software architect and spent a lot of time in this, as well as a member of the UK's Global Entrepreneur Program. I have not received any funding for this talk, and I'm just doing it my free will. So I think that's all on the disclosure side. Why am I really interested in diagnostic errors? I've been talking about diagnostic errors now for coming to almost 10 years, because they are very real. They're hidden, but they're very real. And they're more damaging than treatment errors. And we're going to show you how that is the case. They're more costly to the patient than treatment errors, and they're more costly to the healthcare system. They're reputationally damaging as well. They are demoralizing to those people who are involved, and potentially litigious. And diagnostic errors are sometimes not really what everybody thinks. It's hard to mention diagnostic errors without going back to a landmark publication, which I think really started the whole thing. From the history, of course, I was just getting into medical school at the time that this was published by the Academy of Medicine, which at that time was called the Institute of Medicine in the US. And they published this landmark publication called Error is Human, and showed that medical errors are a major cause of death in the US. In fact, they gave the description that it's like a plane full of people crashing every day. Everybody's dying and nobody's noticing that. So 98,000 people dying annually from medical errors alone. And this was terrible. Like, this was something that they couldn't imagine was happening in the American healthcare system. They showed that most errors were systemic. They were not because of the result of individuals. And the publication led to a cultural shift. I mean, the Clinton administration really took this up and implemented some wide, sweeping changes to the healthcare system. And some of those changes ended up getting into the WHO and getting into our medical systems. And the push for patient safety went into the mainstream. So I think this was a landmark publication, something which I think everybody should read. Makes very interesting reading. It led finally to a lot of massive reduction in medication errors and hospital-acquired infections, surgical errors, etc. An important classification of medical errors that came from this publication was this one. They divided medical errors into diagnostic, errors, treatment, prevention, and others. The diagnostic errors, which we're going to focus on today, is an error or delay in diagnosis, which this is what they classified. That's how they described it at that time. But a lot of emphasis in the subsequent years from 1999 was focused on treatment errors. So we've made tremendous progress on treatment errors, but not too much on diagnostic errors. About 13 years after that publication, the Johns Hopkins released a paper based on a study that they had done. They looked back 25 years and analyzed the medical malpractice lawsuits and found that the lawsuits that came from diagnostic errors were more common, they were more costly, they were more harmful, and tended to lead to far graver consequences for the patient than medical errors, than treatment errors, which was really something that they hadn't even imagined. And my question is this, we have people who are in the US who, the healthcare system is way ahead of ours. If they go and look at their data and this is what they're seeing, if we looked at our data, what would we see? It's just that we haven't, we actually haven't examined our own data. So this is why I'm presenting American data, because they've been open enough to put it out online and to make publications and to say, this is where we are. I would love that we are able to do the same at our end. So shortly after that publication, this came out, which was again now from the same institute that published the paper in 1999. They now published another booklet now focusing on diagnosis in healthcare. Again, a very interesting read. I recommend everybody read it. And what they found is that while a lot of progress has been made on treatment errors, almost nothing has been done in management of diagnostic errors. Worse still, they found that 5% of adult Americans will experience a diagnostic error each year. That's 5%. What is the Kenyan rate? I don't know, but 5% of Americans, that is scary. Postmortem studies showed that diagnostic errors would cause 10% of deaths annually. They were also the leading claim of, leading type of error leading to paid claims, payouts, and death. And guess what was worrying is that most people will experience at least one diagnostic error in their life. Now, this all sounds very alarming, but let's bring it down to the definition of the diagnostic error. What the committee that published this paper, this booklet, defined as a diagnostic error is the failure to A, establish an accurate or timely diagnosis of the patient's health problem, or B, communicate that explanation to the patient. When I was initially studying this, I found this definition to be so mind-blowing. It really opened up my mind to another way of looking at diagnostic errors. That the error in diagnosis is not just that you made the wrong diagnosis for a patient, but if you don't do it on time, if you take too long to make the diagnosis, that's also a diagnostic error. Or if you take too long, or even if you did it on time, but you take too long to communicate the diagnosis to the patient, that's also a diagnostic error, because ultimately it really affects the patient. So a diagnostic error is not just failing to establish an accurate explanation of the patient's disease, but also to explain that to the patient in a timely manner. This diagram was used in this publication to really explain the diagnostic process, and I find it to be quite quite summarized and succinct. It shows here that that the patient will experience a health problem and then will engage with the healthcare system. When the patient engages with the healthcare system, they then will interact usually with a primary clinician. And that primary clinician will be here. They will take a clinical history. They will do a physical exam. They can use various referral and consulting mechanisms, as well as diagnostic testing, to create what is called a working diagnosis. So they gather information, they integrate the information with everything they know, and they come up with a working diagnosis. And what the process of doing this is a circular process, because it means constantly going going back and forth. You find that the patient, you see the patient, you send them off to the lab, they come back with the lab results. Those lab results add to your diagnosis. You add to your diagnostic thinking. When you send them off to radiology, you get the radiology report. It adds to your diagnostic thinking. So this process is the process of coming up with a diagnosis. And once you have this diagnosis, you then communicate this diagnosis to the patient, and then come up with a treatment plan. If it works, there's good, some kind of outcomes. If it doesn't work, you go back to this process. This is a summary of what we all do in our medical practice. And we are here today, we're really looking at radiology. My colleague who presented earlier and myself, who is in the lab space, we're here in the diagnostic testing aspect, or the diagnostic testing part of the diagnostic process, as a support, as a key support to it. I want to focus in on this, and I'm not going to focus on the lab side, on the areas that I think you all know, like, the labeling and workflow within the lab, SOPs, lab accreditation. All of those are very important, and they're pretty standard things in which we all should know. Fill out proper request forms and all of that. I'm going to look at some of the things that are outside of the lab. And I'll just give you a case study from Meru. A few years ago, I was practicing in Meru, and I met a lady. I was running an FNA clinic, and I met this lady. I'll call her Martha. So this lady, she's in her mid-40s, and she has a lump in her breast, in her left breast. This is not the lady, by the way. It's just a picture I got from the internet, so please don't crucify me. The lump in the breast was ulcerating. It has actually ulcerated the breast, and it was quite big, maybe 4 or 5 centimeters in diameter. And so clinically, I mean, that's a stage 4 tumor. And she had been sent to the FNA clinic. So I wondered, why would you send a woman who clinically has a ulcerated tumor to an FNA clinic? I mean, that should go straight for biopsy. It's nothing to do with FNA. But then I didn't know. I didn't follow up on that. So I talked to the lady and asked her, how can I help you? Can I refer you for a biopsy? And she said, when I explained what a biopsy was, she said, I had that done last year. I said, what? And she explained what happened. She actually told me the year before, she had a FNA. She was told to come back a week later, and she found that it was suspicious for malignancy. Then they took a biopsy. Then they gave the biopsy to her, and then they told her where to go and get it sent to Nairobi. So they sent it to Nairobi. She took it, she paid, she went to Nairobi. She sent it to Nairobi, and then she went home, and that was it. And so I asked her why she never came back for the results. The reason, she said, is that she thought that they had excised the tumor. That's what they thought. That's what she thought. She was like, I thought they did surgery. Walisema walitoa hiyo kitu. So in her mind, she didn't have a tumor. And so when it grew back, she came when it ulcerated. This is a diagnostic error. And it's a diagnostic error, even though most likely the biopsy results which came back were correct. It was a diagnostic error for the patient because that patient has probably changed from a stage 2 to a stage 4 because of this diagnostic problem. If we look at this diagnostic side, this diagnostic piece, the lab diagnostic piece, let us trace the journey of our typical patient here in Kenya. You'll find that many times the patient goes to the hospital, and then the hospital procures a tissue from the patient, does a biopsy, does surgery, or does something. And I'm just using tissue pathology as an example, but this workflow happens for other types of samples. They then take they organize this workflow themselves. The hospital, probably the doctor, maybe the hospital administrator, sorry, the hospital administrator will organize the logistics, choose a lab, a partner lab, and then choose the pathologist, sometimes specify based on what they want, and then send the sample that way and pay everybody. This is what they do. Then the pathologist will get it. Pathologist may be in Nairobi, maybe somewhere else. They do the diagnosis, they send it back to the lab, usually handwritten, then the lab types it out, and then it's emailed to the doctor or to the hospital. And this is what happens. Sometimes you find that the hospital sends it directly to a certain pathologist who they like and lets the pathologist handle the rest of the lab testing process and everything. And sometimes the hospital will simply send it straight to the pathology lab and want the pathology lab to handle everything. But we found that about 25 to 30% of people send the patient's relatives to the lab and then tell them to come back with the results. Of course, I mean, all of this causes lots of problems. The clock sign here are places where we find delay. There's often delay at the hospital level, releasing the samples to the logistics guys to take it to the lab. There's also a delay within the lab. Now, for us lab people, we know that processing the samples can sometimes delay, and that means it takes time for the samples to get to the pathologist's desk. And then it gets to the pathologist's desk, there's sometimes delay at that point because the pathologist is doing many other things. They're not aware that there's a case on their desk. They haven't been told, all of that. And so you end up getting delays there. And then there's delays that are there in transmitting these results to back to the patient. So those are points of delay. Then we have points of hazard. The little triangle there is a hazard. And the hazard is where terrible things can happen. Terrible things can happen at this point where you see a hazard sign. And this hazard sign can mean either a mix-up, a broken sample, a lost sample, some kind of transcription error, or something can happen along this, which is a hazard because whoever is doing this doesn't have systems to really thank you for all these hand claps. I really appreciate this. But these are all process delays that and hazards, points at which we subject the patient and their sample to possibilities of a mess. So how can we solve this problem? For the patient, I want to just put things here, that questions that address that people ask, and these questions that people ask are usually not the questions that they already know. They're the questions now that they don't know, that they are having in their hearts. Like, for example, what is making me sick? Where can I go for help? What should I do? When am I going to receive my diagnosis? Hospitals and doctors, the doctor is asking, I've done this surgery. Does this hospital have a place where I can test my tissue? If not, what do I do? The hospital administrator, the lab guy, they're asking, okay, now how am I going to test this in an effective manner? Who am I going to contract? How do I keep track of all these test orders, especially in big hospitals? It's crazy. There could be hundreds of test orders, thousands sometimes in a month. The logistics people want to know, where do I pick up the sample? Where do I drop it? The lab guys want, some labs have a perennial problem. The problem is, how do I keep track of all these orders? I've received 10 today, 15 yesterday, 30 the other day. I'm getting 10, another 8 tomorrow. How do I keep track of which ones are at which stages? Because there's so many stages within the lab process, and keeping track of what is where can be really tricky. How do I communicate more effectively with my clients and with my pathologists? And then finally, for the pathologist, is how do I prioritize the tests? Which one do I start with? Which ones are more important? I mean, I have a stack of 80 cases on my desk. Some of them are fibroadenomas, but others are, Burkitt's lymphoma. I need to, how do I find the Burkitt's lymphoma within this stack of 80? And so you find that there's lots of considerations here, and these are considerations of patient safety. Is it fair to start to go down the list from, when you have one pathologist who has 80 cases and they're going down the list, and the last one is a Burkitt's lymphoma, but they have to go through several, 40, 50 fibroids and fibroadenomas to get to the Burkitt's lymphoma. I think that's not right. So all of these things can be addressed by systems. Now, our company went about solving this problem through diagnostic tech-enabled innovation. We created a digital diagnostic communication and coordination system that sorts out all this mess, so that we're the ones who coordinate and communicate and answer all these questions for these different people. We choose a logistics person. We make sure that the samples arrive on time, correctly packaged, correctly labeled to the lab. We ensure that there's proper distribution to the pathologist, that the pathologists have everything they need and they're able to prioritize, and they don't get overwhelmed with the number of cases by distributing this over a wide range of pathologists. We give them the tools to report quickly and effectively and all that. So the system that we've created has enabled the workflow to go down from 21 days when we initially started back in 2021 to 7 days to 2 days. Now, this is patient safety. This is now really looking at patient safety, not from an internal lab aspect, but from not from an internal lab aspect, from an external environmental aspect. The environment in which lab testing and lab referral takes place needs to be safe for the patient. Finally, just like to say that we are happy that we've been able to recruit now 14 pathologists who we collaborate with, and we're increasing. We want to go up to 30 over the course of next year. And we are coordinating 4 different pathology labs, and this we're going to increase over the next few months. So how can you improve diagnostic safety in the lab in your own practice. My suggestions are this, just practical tips from our experience. Invest in a diagnostic audit in your hospital, in your clinic, and where you are. What does the process look like from the time that you procure a sample to the time that the results are there? Are your clinicians waiting days or weeks to be able to make a diagnostic decision because the process is inefficient? That's just a diagnostic audit, which will really help you. And then if the process is complex, simplify it. Sometimes you find in some hospitals, the doctor will write the request form. Then the nurse will package the tissue. Then somebody, an orderly or a messenger will pick it up from the theater and take it to the lab. Then the lab tech, one lab tech will do this, another lab tech will do another thing. And then finally, so the chain is so long and people forget, people go, night offs and whatever, and they forget to hand over. All kinds of messes happen. And these processes end up affecting the diagnosis of creating diagnostic errors. And another advice is keep track. Whatever you measure, you can control. If you measure something, if you decide I'm going to start measuring my diagnostic times, I'm going to start measuring my diagnostic processes, you will then start discovering where things are going wrong. Find ways of documenting each step. There's so many tools, you don't have to do it. You can just get tools off the internet. There's so many of them, you don't have to rely on your memory. And then follow up on patients. Be open and humble to receiving ideas that can help improve your practice. And then partner with the diagnostic lab or laboratory that shares your values. And there are quite a number of them. Pathology Network is there, but also there are many other amazing labs and lab systems that are out there for you. So I just want to say thank you. That was my presentation. It's a little bit more managerial almost, but I believe that sometimes we focus so much on the clinical side that we then forget that all these other things in which the environment in which we operate affects patient safety. I want to leave with a quote from the To Err is Human, which says that a common initial reaction when an error occurs is to find and blame somebody. However, even apparently single events or errors are due most often to the convergence of multiple contributing factors. Blaming an individual does not change those factors, and the same error is likely to occur. Preventing errors and improving patient safety for patients requires a systems approach in order to modify the conditions that contribute to errors. People working in healthcare are among the most educated and dedicated workforce in any industry. The problem is not bad people. The problem is that this system needs to be made safer. And I think I want to leave it at that and be open for questions.
Thank you very much, Dr. Kibera. That was a very eye-opening presentation. And it's good to see that there's now ways in which we're not just tackling things within the clinical pathways, but we're looking at it as a systemic view. I know when you started your presentation, you spoke about the lack of data and the fact that we have to report based on things from outside to look at the impact that some of these diagnostic errors have. So I wanted to ask about if, or in the institutions where you work, there are ways in which you're collecting some of these errors, if there's an error reporting mechanism, and how then you handle the errors once they come through, because you've also talked a bit about the dangers of having a blame culture.
Yes. So we collect our data internally. We keep track of the things that happen internally in our systems. If we detect a possible diagnostic delay, that's something that we notify the clients. And what we found is also interesting is that if a hospital had been used to getting results after 2 weeks, let's say, or after 3 weeks, or after a month. All the hospital systems adjust to that time frame. And that means everybody plans their lives around that cycle, which ultimately affects, of course, the patients. So when you speed up the diagnostic bit, you then give the doctors, the clinicians, access to diagnostic results in a faster time frame. They then increases the speed of that department, whichever department. And we're keeping track of that data, and hopefully one day we'll be able to publish. Currently, it's just within our company and within our systems. But we hope that this can help other people as well in the future.
Fantastic. And I think just moving on to some of the work that the Pathology Network does, Maurice Aluda would like to ask, how do pathologists prioritize the sample processing using your system? Giving, for example, using Burkitt's lymphoma as an example.
Yes. So what we've done is that because we work with very many pathologists, we're able to batch the samples, the amount of work they get into small bite sizes, so that they get a day's work or two days work at once. That way, unlike other systems where, well, in places where you have a lot of workload, but you don't have this kind of a system, the pathologist will just get everything all the time. And so it ends up piling up on their desks. And it's hard for them to know. But if they only have 5 cases or 8 cases or 10 cases, it's easier then for them to look through that, prioritize. They can also digitally look through the list because it's on our software, and they're able to make now the decision themselves. So that's how we do it, by doing that. But we're also upgrading our software and systems to allow better prioritization using AI and other tools. And of course, if a client says, please prioritize this case, we're able to pass that on to the pathologist who's reporting on the case.
Okay, great. So I think you'd also mentioned delays as being a diagnostic error. So I think at this point, I'd like to bring in Dr. Geshaga and just ask, what are some of the most common causes for delays in getting results from the radiology department? Is this something that has been studied, or is it something that we probably need to gather data on? Dr. Geshaga?
Can you hear me now?
Yes, we can. Thank you.
Local data on delays not available, but the common cause for delays in imaging are, for example, a patient who is a follow-up, meaning they've had previous imaging. So, and we find that maybe the patient has not carried the previous imaging, or they need to look for the previous imaging. That's the common cause for delays.
Okay.
Otherwise, most hospitals and even individual centers have a turnaround time of between 24 to 48 hours for the more complex imaging.
Okay, so Simon Kihara has brought out has asked a bit about the extent of poverty and how it contributes to diagnostic errors. So is there anything that is there any comment you'd like to make on this to either Dr. Geshaga or Dr. Kibera about what to do when patients cannot afford to get the diagnostics processes done?
For sure, this is a real issue. If you noticed, one of the places there is payment. Payments causes lots of diagnostic delays, now leading to diagnostic errors, and it's a system issue. I think that of course, radiology. I think radiology is really far ahead of pathology and lab medicine. So maybe we can borrow a leaf from some of their systems. But on our side, some of our tests are really, really expensive. And I think unless you have systems like NHIF and SHIF and insurances and other payment systems that help to cushion patients from very high costs, it's very tough on out-of-pocket payments. Yeah.
For radiology, we find that the more expensive modalities, which are, CT, MRI, PET CT, we find which we are talking about maybe from 10,000 and above. We have a lot, the general public have good support from NHIF. We find NHIF pays, approves and, assists the public who have up-to-date NHIF or SHIF, I suppose it will be called. It's called now or coming soon. In government, where I work, we have, systems such as waiver systems, which do work for needy patients.
Mm.
And also in government, important to note, children under 5, normally they don't pay for anything. We give free service.
Okay, fantastic.
Yeah.
Thank you so much. And
Maybe,
I think this is, sorry, go ahead, Dr. Kibera.
Sorry, I can just maybe just add, because I just saw a question there, that a potential impact on TAT across public and private sector. What I can say is that for most basic tests, the system that we've come up with is actually cheaper because it aggregates samples and aggregates them to labs and redistributes them to pathologists, allowing cost to be relatively okay for the basic tests. But so for example, histology is around 4,000 shillings, and that includes transportation from Maralal or Kisumu or wherever you are to the lab and to the pathologist and getting the results and SMSing the patient that the results are there and coordinating everything, all of that with 4,000 shillings. So that is not just the cost of the test, it's the cost of the whole service, which is, I think, quite fair. But then costs of things like immunohistochemistry, that's still high. It's still quite high, and looking for solutions, because we charge 10,500 for that. So it's a challenge which I think is beyond us. That's at a higher level. Yeah. Thanks.
Thank you so much. And I think there's also just a question about the turnaround times. So I think from both the laboratory and the radiology perspective, are there any standard turnaround times that exist in the country that we should possibly be ascribing to? Is there a quality standard for a turnaround time that exists?
So the College of Pathology, College of American Pathologists has set its standards, but I tend to feel that for most people, which is 2 days actually, 48 hours, for 90% of lab tests, I've found that for you to do that in Kenya, you'd need to, that's for tissue pathology. There are other standards for other types of lab tests. To meet those international standards, would mean that the costs would go quite high and become quite expensive. But if you reduce that to, let's say, 7 days, for example, for histology, it makes the cost affordable. It brings it down to a point where it can be it's affordable by most people.
Okay. And in the radiology department, are there any quality standards around turnaround times for different scans?
Locally, we have nothing. We have nothing on paper, but in general, most facilities, if things like X-ray and ultrasound, we have a TT of less than 4 hours. CT, MRI, PET CT, TAT of about 24 to 48 hours.
Okay. And for the turnaround times in both settings, whether it's in the laboratory or in the radiology department, do these take into consideration how maybe having some of these services outsourced? So for example, if a scan is not found within a particular hospital and a patient has to go somewhere else, is there a way that that can be factored into the turnaround time, or do we just accept that it might take longer?
For me, it's not factored into the TAT.
Okay.
Yeah.
And on the lab side, Dr. Kibera, is that something that's factored in?
Yes, if we can't do something, we figure out a way to get it done. But we only support specific tests that which we have the capacity to support, and any other test we just say it's just not available on our systems. So that's something which I think is that's all I can say, because if we don't offer it, we just can't support it. Because of course we're a private institution, but we're looking to support as many tests as possible.
Fantastic. Thank you so much. I think there is a question previously, just looking at how to resolve any discrepancies between maybe, for example, the clinical history that is taken by the radiographer versus what was done by the clinician. So I don't know if, Wendy, you'd be in a position to have a look at that question. It's from an anonymous attendee, and they also had asked about administering contrast in trauma patients. So there's those two questions, if you would be able to address those. And to you, I think, and to both of you, there's another question around what would a patient do if they feel that a diagnostic error occurred, but of course they cannot quantify it. Is there somewhere they can report, or is there something they can do? Is there a framework that can assist them without bias in making such a report?
Okay, so I'll just answer the questions from my end pretty fast. I can answer there was the previous question on bone conducting hearing aids. They are titanium, they are of titanium material, therefore they are safe in MRI. The next question was when a patient for MRI comes in with, when a patient for imaging comes in with a request form, and you look at the request form, it has a clinical summary. The radiographer will read through the clinical summary. We'll ask the patient, if, say, for example, the patient has been sent for a CT abdominal pelvis. So the radiographer most likely will ask the patient, where is the problem? Is your tummy aching? Do you have a swelling somewhere in the tummy? The patient may concur. Some patients will be like, no, actually, it's my head which is paining. So in such a case, most radiographers will defer to the radiologist. Then the radiologist will speak to the patient. If they are not able to determine why a CT abdomen is being asked for and the patient is complaining of a headache, then we call the clinician and discuss. There are no ethical issues about the radiographer getting a clinical summary from the patient. If there's a conflict in what the patient says and what the clinical summary is saying, that's when we reach out. And the last question, CT contrast in trauma. That's so broad because a trauma to abdomen, head, limbs. When you have trauma to, say, I would imagine when we are talking about IV contrast, we are talking about abdominal trauma or probably head trauma. Head trauma, first line is a CT scan without contrast. So we do not use contrast in such cases. Trauma to the abdomen, there are certain protocols which are followed. You start with an ultrasound, then the ultrasound will guide you on whether you should proceed CT. But now the teaching is that if you're going to proceed to a CT for abdominal trauma, then you give contrast, IV.
Thank you very much. So I think we can move down to some of the questions. There's a question from another anonymous attendee about some of the practical ways to capture data for improvement, especially when you're looking at things like delays in diagnostics and failure to communicate to patients. So I don't know if there's any tools that you're currently using or if there are any indicators that are being captured, whatever your work around this, that maybe we can borrow a leaf from.
That directed at me?
Either of you, if there's something you're using, if there is something that even is in development and you would want people to test, I guess we'd be able to find some people in the audience who would be willing to help.
Okay.
Because I think
Okay.
we've talked about turnaround times, so measuring when a patient presents, I guess, their request to when they actually get. For example, the report at the end of it is something that can be measured. So is there any other specific indicators that people could be looking out for and measuring actively to see how they're doing?
Yeah. I think we need to be quite, open to developing our own tools. We at the Pathology Network, we developed our own tools and we created our own metrics to measure the time. For example, the time between when the sample was removed from the patient, as indicated on the request form, to the time that it arrived at the lab. That's kind of like a lost time, and sometimes that can even be days. So we measure that, and it's not within our control because a lot of that is within the institution, that within the hospital. But at least we measure it so that we can give that data back to them and tell them this is how you're doing. Then they're able to act on it. Then we measure the stages after that as well, and we use various digital tools. But we started off by just handwritten registers and having a specific person. What I've found is that if you take a professional, you take somebody who is a professional in an area, they're a lab technologist, they're a doctor, they're a nurse, there's someone who's a professional in their field, and then you tell them to do something that's not in their job description, they haven't been trained for it, they may not do it as well as if you got a specific person who that's their job is to measure that. Then they end up doing a very good job because they keep track. It's like air traffic controller. It's a completely different job from the job of a pilot and the job of the people who flying the air traffic controller. Their job is to make sure that all the things are in planes are taking off and landing properly and all that. So the same thing, there needs to be someone else who stands on the side, keeping track of what's going on the field. So that's my thinking. Tools can be very helpful, but still we need to sometimes assist the people who are using the tools. Yeah.
Thank you, Dr. Ari. And to Dr. Gishaga, are there any quality indicators that you regularly track within the radiology department as well?
Where I work, no. I don't know the situation in our big referral hospitals. Let me not commit. I'm not aware.
Okay.
Yeah.
So I guess if there are any people who are willing to start looking at this, you can always get in touch with our presenters. So I think with that, I'd also like to ask Dr. Kibera, there's a request for how people can reach the pathology network in case they were interested in partnering.
Yeah, we have our on the internet. We're there, pathologynetwork.africa, and also you can reach out to info@tpn.africa or help@tpn.africa, and we'll get back to you. Yeah.
Fantastic. So I think we'll also just touch a little bit around some of the technology that's coming up. There's everybody talking about AI these days. Is there space where AI has in making diagnosis safer? And have you seen any examples of this within your practice? This is to both you, Dr. Kibera and Dr. Gishaga.
Okay. AI is a hot topic, especially in radiology. Here in Kenya, I do not know of any facilities which are using it. But in the West, they have started to use it, but it is not used it's not used alone. It's in conjunction with a radiologist. So just a practical example, an image is generated, passed through AI. The AI gives, a diagnosis and a differential. And the radiologist then goes through the image again and signs off on whether they agree or disagree with what the AI has come. So alone, no, but in conjunction with a radiologist, it is being used, yes. And it has shown to be quite beneficial, especially in screening mammograms.
Fantastic. And Dr. Kibera, in the lab setting?
Yes, in the lab setting, again, just like Dr. Arya said, in radiology, AI is a pretty hot topic, and it's likely going to be able to increase the speed of the diagnostic process. At the moment, just like Dr. Gishaga said, it's really a kind of like a co-pilot. It's an assistive tool to help the radiologist or the pathologist to report slides faster. So we don't have well, actually, there are 2 or 3 algorithms that have been licensed by the FDA for diagnostic use, but even then, they're mostly used as co-pilots, not giving the primary diagnosis. However, this is going to change. I can assure you, the next five years or so, you'll probably have some diagnosis being released by AI at some point, just because of how good the systems are becoming. But there's always that need for the human being, because of the mistakes that AI makes, especially on things that it hasn't been exposed to in a broad, broad. a broad spectrum of things, because sometimes we have reasoning as human beings. We have intuition. We can tell there's something here that doesn't add up, but the AI doesn't have that. And so that becomes a bit of a problem, which is why you need human intervention. Also, AI struggles, especially in pathology, it struggles with benign diseases. Cancer, interestingly, is quite amenable to AI, but benign conditions, inflammatory conditions, things like that are a bit out there, it's a bit tough for AI. We're also looking at developing workflow AI that can predict things. And maybe once we develop these systems, we maybe even be able to help, government hospitals and others with workflow AI that says you have these many patients in your queue, and you have these many radiologists, you have these many pathologists, you have this work in the lab. We suggest that you distribute it like this. Send this one here, send this one there, just organizing the hospital. I think AI is going to be those kind of tools. If some of you can come up with some of those tools, that's a great opportunity for entrepreneurship, tech entrepreneurship, and I hope somebody can take it up. I think it's a good use case for AI.
Fantastic. It's good to know that AI will be something that complements our work streams, not takes over our jobs. And so I think just looking at the human touch, there's an issue that's come up about repeat tests. And it's also one that I'm sure many of the people in the audience would be wondering, when should a clinician actually request for a repeat investigation? Would it be a scan, whether it's a scan or an MRI? Is there any guidelines as to when you should repeat a test that you know of?
I mean, there are many reasons why a clinician would ask for a repeat. One could be the new symptomatology of the patient or missed symptomatology. Two could be lack of trust from the clinician on the conclusion that has been reached. If a clinician doesn't trust the imaging center that the patient went to, they may send them somewhere else for a repeat. In such cases, if the patient comes comes with the imaging that they had done previously, it's only prudent that the radiologist goes through the images that the patient walks in with and see really, are the clinician's actions justified? Is he just biased that he does not like that imaging center, or he doesn't trust them, or he has bad history with them? Go through the images and compare with the report and see if you agree or disagree. Then if you disagree, then a repeat is warranted. But if you agree, then there's no need to do a repeat. You need non-honesty. You call the clinician and communicate.
Fantastic.
And in terms of, I spoke about it, patients who may lose the copies of their report or the images, we don't need to do repeats anymore because of the PAC system.
Fantastic.
Thank you.
And in the lab side, Dr. Kibera?
Yes, similar to what Dr. Ari has just said, there are many reasons for repeating a test. And maybe we can break them down into two broad categories. One is, professional clinical reasons for repeating a test. And these could be because of an algorithm, for example, you started on treatment, you are following up to see whether the treatment has worked, so you repeat the test. Or or because, there was an insufficient sample because of a certain criteria. So for example, in thyroid, let's say you're aspirating a thyroid, doing a thyroid FNA, you aspirate a thyroid FNA and you get a cyst, and the cyst, the fluid it's just fluid, there are no cells. If there are no cells and it's just fluid, yes, you were in a cyst, but without fluid, without cells, what can the pathologist say? The fluid could have come from anywhere. And that causes its own challenges. So those are now professional, clinical reasons based on criteria for repeat. Then you have medical legal reasons for repeating a test. And those ones now have to do with, issues of, not trusting, wanting a slightly different opinion, feeling, personal and medical legal reasons. Those ones are really not clinical, not based on a specific criteria, written criteria.
Okay, thank you both very much for taking time out of your busy schedules to open our eyes to some of the diagnostic errors that can happen and what we can all do to help prevent them and make sure that our patients get the right diagnosis and are kept safe. There are still some questions in the chat box. Hopefully we'll be able to do future webinars to address some of these. Maybe we can do themes around some of the issues that have come up in the questions. And I'd just like to thank everyone who's taken time to put questions through for us. With regard to CPD inquiries, I think the research team at KNH will be addressing this, and hopefully they've taken note of the people who have asked about these in particular. And hopefully we'll see you in our next session, but thank you again for your attention and for being such an active audience. And do give some applause to Dr. Gishaga and to Dr. Kibera for taking time. Thank you all and have a good afternoon.
Thank you.
Thank you.
Bye-bye.